Thank you for joining us for today's webinar, Do I Remember How to Operate? Returning to Clinical Practice After an Extended Leave, hosted by the ACS Women in Surgery Committee. Please use the Q&A box to submit questions for the live Q&A portion today. A recording of this webinar will be made available. Our moderator today is Dr. Niru Anne. Dr. Anne is an associate professor of surgery at Penn State Milton Hershey Medical Center. She received her MD from SUNY Upstate Medical University, Syracuse, and completed her general surgery residency training at Northwell Health Systems and a fellowship in surgical oncology at Roswell Park Cancer Institute in Buffalo, New York. With nearly 18 years in clinical practice, Dr. Anne has previously served as the medical director of the breast surgery program at Prisma Health System in Greenville and Columbia, South Carolina, and was appointed to the University of South Carolina School of Medicine. She was also the chairperson for the Department of Surgery at Our Lady of Lourdes Hospital Guthrie System in Binghamton, New York. Dr. Anne's career is marked by active leadership in several national committees, including the ACS Women in Surgery Committee, serving as the current chair of the Mentorship Subcommittee, the American Society of Breast Disease, as a past member of the Abstract Selection Committee and the Breast Specialty Training Committee, past president of the Broome County Medical Society, past vice chair of the Medical Society of the State of New York, organized medical staff section at the state level, and a past physician leader of the Broome County Health Advisory Board. Dr. Anne holds appointed roles with the American Board of Surgery EPA Writing Group for Complex General Surgical, the Society of Surgical Oncology Breast Surgical Oncology, and the American Society of Clinical Oncology Guideline Expert Panel. Dr. Anne, thank you for moderating today.
Thank you for joining us today for our conversation on returning to clinical practice after extended leave. We're joined today by Drs. Burlew, Geeta Lal, and Deborah Nagle. Dr. Burlew is a professor of surgery at the University of Colorado and is a program director of the ACGME-approved Surgical Critical Care Fellowship and the AASD-approved Trauma and Acute Care Surgery Fellowship. She earned her medical degree from UT Southwestern and completed her general surgery residency and surgical critical care fellowship at the University of Colorado. Dr. Burlew is an active surgical investigator, an educator, and a clinician, and she had received multiple awards in each of these areas. She currently serves on the board of managers for the American Association for the Surgery of Trauma as a secretary and treasurer. She's on the GSCE Trauma Vascular Committee for the American Board of Surgery and is a past president of the Southwestern Surgical Congress. She is on the editorial board of the Journal of Trauma and Acute Care Surgery and serves as the associate director for surgical critical care. She had authored over 250 peer-reviewed articles and 90 book chapters, and she has given over 100 national and international lectures and scientific presentations. Dr. Geeta Lal is a tenured professor of surgery and pediatrics at the University of Iowa Harvard College of Medicine. She received her medical degree from the University of Toronto and MSc at the University of Toronto, and she completed her general surgery residency at the University of Toronto and a fellowship in endocrine surgical oncology at the University of California, San Francisco. Dr. Lal had served in many different leadership roles throughout her career. She previously headed an NIH-funded basic science laboratory and was the Associate Chief Quality Officer for the adult inpatient services at her institution. She currently co-leads the Cancer Center's Endocrine Multidisciplinary Oncology Group and continues to maintain a very busy endocrine surgical practice. Committed to increasing awareness of and development solutions to counteract the impact of poor ergonomics on surgeons' professional and personal lives, Dr. Lal actually founded Surgical Ergonomics, a speaking, coaching, and consulting business. She is a co-founder and immediate past president of the Society of Surgical Ergonomics and is the current chair of its Industry Collaborations Committee. Her advocacy on this topic has led to the incorporation of an ergonomics module in the Surgical Council on Resident Education curriculum. She also has co-authored the first chapter on ergonomics in the upcoming edition of the Saveston textbook of surgery. Dr. Deborah Nagle is the chief for the Division of Colon and Rectal Surgery and the professor of surgery at Stony Brook University Hospital and Cancer Center and is on the scientific advisory board of Exera Medical. She received her medical degree from the University of Pennsylvania and completed her general surgery residency at the University of Pennsylvania Health System. She did a fellowship in colon and rectal surgery at Thomas Jefferson University Hospital. Previously, Dr. Nagle worked for Ethicon as an integrated leader, digital surgery leading cross-functional group in evidence generation strategy for a digital surgery system incorporating preclinical, clinical, and medical efforts, and was a medical director of endomechanical and surgical oncology. Prior to Ethicon, Dr. Nagle was an assistant professor of surgery at Harvard Medical School and the chief of division of colon and rectal surgery at Beth Israel Deaconess Medical Center. During her time at Beth Israel, Dr. Nagle was part of the team that developed the technique of the single incision laparoscopic surgery and began the first robotic colon and rectal surgery program in Massachusetts. Dr. Nagle is a member of several national organizations and societies, such as the American Society of Colon and Rectal Surgeons, Society for the Surgery of the Alimentary Tract, the Association of Women Surgeons, the American College of Surgeons, and many more. Dr. Nagle is driven to improve patient and physician outcomes through education, biotechnology, and practice management innovations, and she's energized by the challenges in surgical care and helping patients navigate through difficult choices with goal of best possible outcomes. I'd like to thank each and every one of you for being with us today. And at this point, I'd like to start the conversation of returning to clinical practice after extended leave with maybe asking Dr. Burlew how she knew when she was ready to return to clinical practice after taking time off.
So this is always a complex question, and I think that each of us likely have a very different reason that we stepped away from clinical practice and came back, and obviously that impacts each of our answers. For me, it was a combination, first of leaving a difficult workplace and finding a new job, but then it was complicated by having emergent surgery and then having complications after surgery. So for me, it was a combination of sort of two very sudden life events that sort of happened one on top of the other. So for me, returning to clinical practice was both finding the right next job and next step of my career, but it was also limited by a health complication, which I think became the more predominant issue in my return to clinical practice. And so it really wasn't until I was able to be medically cleared and felt confident in my health ability and my stamina to return to clinical practice and to really resume an active clinical schedule.
If you don't mind me asking, how long were you off? How long did you take time away?
It was about 9 months, 9 to 10 months by the time it was all of those things were said and done.
And when you felt like you were medically cleared and you could come back, did you have any hesitation about just jumping right back into clinical care?
I think no matter how far out, I mean, even though I was more than 20 years out from my training, this was just a year or two ago, I think the level of experience perhaps made me a little bit more comfortable in coming back after that long of a break. But I think all of us have a question of, walking back into the clinical realm, and will all that decision making still be there, and your ability to be in the operating room and lead a team. And so I think for me, it was natural. Plus, I was starting a brand new job at the same time. So I was also trying to step into a role where I didn't know the individuals. I didn't know my operating team. I didn't know, I didn't even know my way around the hospital on the first day. So I think that's normal. I think for me, it was important to surround myself. I did know some of my partners pretty well. really leaning on them and asking questions. Okay, let's be really specific about where I'm going. What are the expectations? What is this clinical environment? Am I ready to step back into something that has this amount of rigor? Am I ready to, for me at the beginning, I didn't take overnight call. For example, how can you set yourself up for success in that situation? I think that was really the big question for me.
Dr. Lal, when you returned to clinical practice, what was the hardest or the most surprising, about returning to clinical care?
Thanks, Dr. Anne. And I think I want to thank Dr. Burlew for initially just stating, I think all of us have had our reasons for stepping away from practice. And so I'll share my story. So I stepped away for an extended period of time, probably about 7 to 8 years into practice, when my mother was diagnosed with cancer and I had to move to Toronto to kind of take, care of her and my dad. And so I was gone initially intermittently, maybe 2, 3 months, but then I took an extended leave, which was probably about 8 months to care for my mother, in kind of her palliative. And then I took another leave of absence, this time maybe for about 2.5, 3 months, similarly for my father. And that was just before the pandemic. And somewhere in between those two, I took about 4 to 5 weeks off of operating for myself because of, you've explained about my interest in surgical ergonomics and related to my own sort of neck pain from operating. So I've had 2 or 3 different scenarios. Like Dr. Burlew said, it is really important to kind of plan things out. Like for my longest time away, which was the 8 months, coming back, obviously division members and my division director knew the circumstances under which I had taken the leave of absence. They were helpful in kind of facilitating my navigation back in. I did wonder, even though I was 8 years in, but I did wonder, am I going to remember how to operate? Am I going to be able to lead in the OR? I had been doing academic work while away, but I had not, been in the operating room for months. So I had a similar sort of, setup, even though it wasn't my medical reasons. It was still kind of dealing with the logistics of taking care of the other parent, long distance, etc. So for the first month, it was like, well, you don't have to do night call, just get yourself back into clinic and, then set up your cases, etc., just like you. But I think that also turned out to be surprising because on my first day back or first week back, I had a call from a referring physician saying, I heard you were back. Are you seeing patients? And then immediately our chair was also in our division and he got called to an urgent meeting. And he said, you're back. Can you cover my schedule today? Yes. And so my plan for easing myself back in went out the window. And I was back in with the residents doing somebody else's cases, obviously after meeting the patient. So what was surprising was that the best laid plans can often be waylaid. And I won't say it's muscle memory. It's more than that. But what was surprising to me was within half an hour of kind of being in that situation, I was able to kind of adapt and it felt like being,
Like old times.
Yeah, like old times, like comfort. But I was in the same place, right? I was familiar with the residents, I was familiar with the nursing staff, and I was familiar with the institution. So those are
Sure. That probably helped being in the same place rather as opposed to starting a new job where you have to figure out everything.
Right. And that's why I made that distinction that, I think for me, the surprise was, okay, you didn't need as long as you thought, but also the environment you're coming into.
So, Dr. Nagle, what did you find to be the hardest when you returned to clinical care, or the most surprising or challenging?
So my story is a little bit different because I chose to step away from clinical practice to work in industry. And I did that for 3 years in the hope and belief that I was going to help make surgery better for all surgeons. And what I ultimately found out was that there were great things about it, and I really, really loved the experience. But I was so differentiated down the surgeon pathway that I missed the engagement with patients. So when I went back after 3 years, And I operated, but only in a lab setting, only with, how shall we say, non-sentient patients. I found that the things I worried about were the big things we all worry about as surgeons. So the first time I went to do, and I was in a new hospital with new people and didn't know anyone, and I prepped for that. I was working on a different robotic system or one that I hadn't used previously. I did some training before I went in there. I made sure my cards from my previous hospital came through, all that, but still I found myself up and down the hallway, talking to myself, saying, you got this, you've done this a million times, you know these steps. And what hit me the most, what was the most difficult, was realizing the stress that we are all under as surgeons operating on living human beings who expect us to provide the best possible outcome. And living into that again was the part that I found stressful. It wasn't the technical part, it was the part.
Sure. So when you started back up, since you do colon and rectal surgery, did you start with small cases and then build up to big cases, or you just went and took care of anything and everything just like Dr. Lal did?
No, I actually went into a hospital system where they needed to have a robotic surgery program built. And so I went that mandate. So I went into surgery right away. I personally put myself through some training on the system. I did have required mentorship because I was in a new hospital, and that's super normal for robotic. But I would say, no, there wasn't easing in, there was launching it. But speaking to the muscle memory, like I remember all those cases. Yes, it was about re-embracing with taking care of people who are putting their lives in your hands. And you want what's best for them every day.
Sure. You were in practice for how long before you took the 3 years out?
15 years.
So you were pretty comfortable and.
Yep, I was super comfortable. But it was surprising that after all that time, I then turned around to go back and said, ooh, am I sure I've got this? What else do I need to do to make sure I'm comfortable? It took me, I'm going to say, 3 months to feel the same level of confidence that I had before I went out.
Sure. And you said that, there were a couple of cases that you had to have mentored by, because it's a new hospital, but that's probably like less than 10. It's not like someone was there to help you transition in or anything like that.
Correct. It was really about just the normal robotic proctoring when you're in.
Sure. So were there things that you did besides training on the robot that in terms of and setting up your OR cards and everything, did you work with the nursing staff or residents, or were there other things that you did to try to ease in, because these are not small cases?
Yeah, you know what I did? I leaned into the people that I used to work with before. And I literally called my nurse practitioners and said, because the things that you don't remember are little things, but they were a big deal when you're practicing. So what is that drug? And so I would literally say, what's that drug we used all the time? And what was the correct dosing for that? So I gathered all the previous patient teaching information that we had from my prior hospital that I developed with the nurse practitioners. I looked for other colleagues, not in my hospital, but in my specialty. And I went to visit them and I said, let me see how you're doing this. What's your new technique? I reached outside the bounds of the hospital that I was going into to try and reactivate my knowledge of every current moving part.
And so then I have to ask you, what is something that you wish you knew about returning to clinical practice that you kind of knew before leaving clinical practice?
It's just as hard. The rewards are as great and the pain is as great. It doesn't change if you leave. I mean, I'd be interested to hear what other people say, but there's very little that gives you the reward of clinical practice. And there are things that offer so many personal challenges.
Dr. Burlew, what do you wish you kind of knew before you left or when you came back in retrospect?
In retrospect, I wish I had known how exhausting those first months would be. I think I underestimated. I just assumed that I could sort of walk back in and that this would be a piece of cake. And I think, my advice would be for anyone who's making this type of transition or this type of step away and come back is to make sure that you give yourself space. Don't take on 2 other brand new projects at the same time that you're trying to do this step back in. Because I felt that this really was sort of all encompassing for those first several months as I was coming back in. And then I think secondly, ask really specific questions. Be really clear about if there are requirements for coming back. For me, mine was related to spine surgery. So there were specific medical hurdles that needed to happen. I needed letters from my spine surgeon and my rehab doc and different specific qualifications and permissions that had to happen. And so I think making sure that you have all those pieces of knowledge way in advance. You can't, just as we have trouble giving a doctor's note, trying to get a doctor's note to go back to work is for all of us. So make sure that you understand the milieu of different items that you need as you re-enter, because each place is going to be different and that process is going to be different.
So did any of you at your institutions have like any sort of institutional guidelines for re-entering clinical practice? For example, Dr. Lal, when you were gone for extended period of time, or even Dr. Nagle, when you came back 3 years later, did they have like guidelines saying that we need you to do a re-entry pathway or X amount of cases being watched by proctored, or we'll look at your outcomes for the first 50 or 100 cases, anything of that nature?
That's a great question. I'm not sure. I'd be interested to hear what, others' experiences were. I did not have any particular reentry requirements because maybe I was coming back to the same institution and people, that knew me. So other than kind of re-establishing sort of the clinic protocols and then getting my operating room block time had been taken over by somebody else, then showing that I could fill the operating room again so I could get my block time back, etc. Luckily, I did not have to deal with kind of particular requirements. Our institution usually has every 2 years, you have that clinical recalling committee. So I didn't, and I had to explain that absence, obviously, that I wasn't surgeries for X number of time because I was on a sanctioned leave of absence. So other than that, I did not have any formal requirements. I will say that one of the things that it's important to remember, and this might address a question that's in the Q&A, but I wanted to just state this, that sometimes the barriers are in our head. And I wish I knew, like when you asked, Dr. Burlew and Dr. Nagle, what I wish I knew was that it was okay to take the time out that I needed to care for my family member, which was really hard to do long distance. Okay. And that I didn't need to justify that. I just needed to say that this is what I needed. Now, clearly I was in a supportive environment and there were 2 other surgeons doing what I did. So it was possible to spread the load. Only surgeon, then it's not possible, but it was possible to spread the load. But sometimes I think we think a lot about, well, I really can't take time off, right? So I want people to understand that whatever life event it is that is causing you to think about taking time away from practice, whether it's, short period or long period, if you feel that that is necessary, do pursue it. And then you might find that there are options that you can do. So that is a surprising element that I wish I knew ahead of time. It was much easier when the time came for my father. I just went back and I said, remember how we did this for my mother? I don't need 9 months off, but I need 2 months off,
Well, do you feel like today, like the society today is more accepting of people taking time off than maybe 10 years ago? Because, did any of you face any sort of judgment from your peers or people kind of not like treating you well or like looking at you with a magnifying lens or anything like that just because you took time off?
So I'm just going to share that when I was a resident and a junior attending, I had only male partners who were not supportive of me participating, being a mother outside the hospital. So I literally would say that I had a dental appointment when I wanted to go to preschool show or something else. Dimly, somebody turns around and says, "Wow, you seem to have some teeth problems." Like,
Yeah.
what? Right?
A lot of teeth issues.
Right, right. So I think that we all have faced challenges in terms of speaking up for what we need and what's the
Mhm.
right thing. And I'm really happy to report that I have multiple junior faculty, and they are equal. Men and women are equally willing to say what they need now, which I think is terrific.
What about Dr. Lal or Dr. Burlew? Either if you experience anything of that nature or not really?
I was going
You
to say, I absolutely agree. I didn't, if I had known, I would have used the dental appointment. That would have been brilliant. Um, but yes, a same situation when I was pregnant with my daughter. Again, this was 15 years ago, over 15 years ago. We stepping away, I felt bad about every day after,
Mhm.
having a C-section that I was gone before I came back. And I was, and I, so, each week I just was stressed because it wasn't,
Mhm.
I was with only men, and you could just feel that pressure to come back. And so I think I was
Mhm.
gone for maybe 2.5 weeks. Um,
Yeah.
and I think that now we are much more adept at having the conversation of what each of us needs to be a healthy partner, both
Mhm.
men and women. And so it is a much more common conversation to have about leave of any duration. Particularly, I think it just was perhaps best introduced through parenting leave. But
Mhm.
I think that it is much more accepted now that when you say so and so was out for 3 months, people don't.
Dr. Lal, anything you wanted to add regarding that?
No, I agree that, obviously I don't have children, so I can't speak to maternity kind of leaves, etc. But I appreciate what you say because I've seen several colleagues do the similar things, Dr. Nagel. But it's, um, uh, yeah, I don't have anything other than to say that, yes, I think the culture is changing, and the conversations happen more readily than they did perhaps when I entered practice 20 years ago. But there's still work to be done. Yeah.
Sure. And you mentioned partners who, some junior faculty that are able to take time off. I think it was Dr. Burlew who had mentioned that it's mostly, I'm thinking, related to medical leave or pregnancy or something of this nature, right? Because I find it very unique that Dr. Nagel was able to take 3 years off and work for industry. Not in a bad way, but it is unique to be able to step away completely and then come back. So, what was your decision to step away?
I felt like I had done as much as I could in the environment that I was in, and I frankly had burnout. When the
Mm.
ACS burnout survey came in, I remember sitting in my office, filling it out one night and saying, "Wow, I got 100. I got 100." Um,
Yeah,
it was a combination of factors. But I think the thing that I hope people come away from this discussion with is that it is okay to choose to do something else, and that we as surgeons have multiple options. And that's what I think people aren't sure or confident about. We get so down the pathway of being a surgeon that we don't say, I've got a great skill set that's applicable in other areas. So,
sure.
and for people to come back, they're worried about fitting in. I think that I'm going to guess that based on all three of our experiences, especially me coming back after 3 years going to a new hospital, I wasn't asked anything about the previous 3 years. I was asked to do
Mhm.
the normal medical staff application and entry. So
Sure.
I'm not sure what challenges are out there for people on different pathways, but I
Mhm.
kind of feel like we should think we have more flexibility than we do. Or we have more
Sure.
flexibility than we think we do.
Sure. So we're going to move on to the live question and answers portion of the webinar. And it looks like one of the attendees had requested, as female surgeons, how to deal with maternity leave and feeling, I guess, less competent than the male colleagues if you took too much time off? Who wants to answer first?
I mean, as someone who took a very short amount of time off, take the time. You will not get that 3 months back of your child's life. You will, I mean, I regret not taking more time of sort of caving to the stress and the pressure of why haven't you come back? You will be fine. You will still be a surgeon. You will still have all of your surgical skills. I wouldn't think twice about taking 3 months off, personally.
Dr. Nagel, did you want to comment on this?
I totally agree with Dr. Burlew, and that we are programmed to believe that we have to be there all the time, and we can't say no for ourselves and our families, and you never get back that time. So if you can take it, and you will catch up. If you're early in your training while you're doing it, or early in your practice, of course you're going to feel more unsure. It's totally different than being 15 years in practice, as I was when I walked out to go to industry. Totally different. But you're still going to catch up. It's all going to even out.
Someone else posted a question saying, how did you deal with your first complication after returning to clinical care? Did you blame it on your time off from practice? Dr. Lal, did you want to take this?
Sure. I will take this question, but I wanted to address something that you asked, if I may, in your previous question. I can't answer the maternity leave part,
Sure.
but I agree with Dr. Nagel that the earlier on you are, the more unsure you are. And, it's when, like she said, you lean on your colleagues. So if you're coming back and you have a complex case and you haven't done it for 9 months, perhaps see if there is a partner who can co-scrub with you on that case. Just sort of that, to have that coaching voice should you need it, or at least make sure that they're available that day and they're not operating at a different hospital should you need it. You likely won't, but it's always good to have that preparation. At any level you can feel incompetent, but you can kind of, set up sort of support system for yourself. Regarding the complications, I think complications at any stage, irrespective whether you've taken leave or not, always we tend to turn things inward, right? It's the way we have been kind of trained in surgery. It's your fault. What could you have done differently?
Differently.
Yeah,
It's a knife in the heart.
right. And yes, that's a good way for introspection, because indeed we have to examine that question, because if there is something that we can do, it's important to address that, but it's also important to address system things, right? And one of the things that I realized when I had kind of a nerve injury after coming back was to remind myself, or at least have a friend or a partner remind me, that you had those even before you took leave, right? There is an intrinsic complication rate of working around the recurrent laryngeal nerve, and it's not to do with, your being away. Now, if you introspected, spoke with a colleague, trusted colleague, mentor, and feel like your skill could use some improvement, then again, not being ashamed, and seeking out ways to do that by having kind of a partner available, or scrubbed in with you while you kind of retool, in whatever respect is needed. I guess there's no cookie cut answer. It just depends the circumstances you're in, and what kind of environment you're in.
Sure. So I guess there's another post about, should we mention on the CV the leave and the duration and the reason why you left clinical practice and why you're coming back. Is that something that should be done? So that's more like an advice as to what do you guys think?
Oh, I think that's a big win. I
Mhm.
think that the problem is that people are thinking that it's a loss, and it's not. It's a win. It's another life experience that adds to your ability to be a surgeon, to be a compassionate surgeon, caring for other human beings. Doesn't quite matter what that timeout is, but it gives you
Sure,
greater insight and greater ability to be a holistic practitioner. I would absolutely just turn that into a win. And even if you're
sure.
doing like Geeta had to go and do, chose to do, didn't have to, sorry, chose to do caregiving with her family members. That is, that is all about compassion, bonding, building relationships, all things that make us better surgeons, choices that make us more holistic, empathic surgeons.
There's a gap history, it looks like that's similar to yours, Dr. Nagel. There's someone who had mentioned that. And they wanted to know how you were able to navigate getting a new job because they had stepped away, and it seems that they have been doing uh, kind of like veins only for 3 years and not able to find a job that would allow them to do everything else.
So I can't speak to vascular specifically, but it is true that people go into one subspecialty area, so to speak, and then want to generalize again, I guess is maybe a good way to look at it. So for that, I would suggest reaching out to your mentors who have guided you through residency and practice to find out what the opportunities are to have them advocate for you. That would be my thought on that. I don't know what the other doctors think.
So, Dr. Lal, do you have any advice related to this?
So I think there's I think on our panel, we're fortunate that we were able to kind of re-enter from
Mhm.
our different pathways. But I see this kind of mirrored in some of the online Facebook groups that I'm a part of. And I think I'm seeing that in the questions that you're asking as well, Dr. Anne, from our live Q&A chat box. There seem to be a lot of barriers for people that have stepped away for whatever reason coming back, whether it's the local
Yeah.
hospital environment, partners, etc. Even when their partners want to proctor them, sometimes it's administrative related, and it's either credentialing at a hospital or it's like meeting American Board of Surgery requirements. So the question is, did we, while people are away, did they lose their state license? Did they lose their ABS certification? Those things obviously make it harder. And then I
Mhm.
think another driving piece is, which we aren't really talking about, and I think that kind of ends up being a big barrier, is if you can't get malpractice, like the malpractice companies are making these requirements that you have to have practiced in the last year or in the last 2 years, and otherwise you can't get covered. So even if the hospital wants to hire you and you have people willing to proctor you, etc., if you can't get malpractice, then they can't, get in. So there are all these other factors other than the ones that we've kind of outlined. So I just kind of wanted to bring that forward as well.
Sure. So, like the Endocrine Surgical Society, does it have any guidelines on reentry process? Not the ACS, since I mean we have the reentry pathway, and I'm going to have Jenny follow up on it after the webinar and circulate to all the
Yeah.
attendees on how to find that. But is there anything specific, specialty specific in colorectal surgery or, surgical critical care or endocrine or anything that you guys are aware of?
Not that I'm aware of, again, but I took care while I was away to keep my recertification, exam,
Mhm.
stay in
Up
that,
to date,
yeah, up to date, keep the hospital credentials, etc. But I
of
think
course.
a lot of it had to do with the fact that I had a supportive chair and division director,
Mm,
and I was able to just get back in. But I realize not everybody has that same.
So I would totally echo that, because when I left to go to industry, I actually didn't think I was going to come back to practice, but I never let my board certification lapse. I kept my CME up, even if I had to go to alternative pathways besides being in a hospital. I continued to go to major, my major meetings. You don't know for quite some time, right? And so
Sure.
I think it's very good advice to say you're just going to keep going as if you're a practicing surgeon until you're sure you're not.
Sure. I guess there's a couple more questions about how do you overcome the negativity of the reentry, and also is there a way, how is the insurance company, how did the malpractice work? I don't know much about the malpractice in terms of ACS resources, but was the malpractice insurance different when you guys re-entered, or I wouldn't think it would be. It would be the same rate, right?
Right.
Okay.
I mean,
So
I don't have any knowledge of that, but I mean, I did go to a different institution. I think Clay did too. But if you're in the same state, it's likely going to be the same.
Mhm.
For
Yeah,
the negativity, I would say that there's negativity when you go out, and there's
Negativity when you go, when you come back, and
yeah.
when you're trying to re-enter the system.
Right. So you have
Yeah.
to be aware. And I was frankly shocked that there was negativity when I left, and it was suddenly like I wasn't part of the tribe anymore. So that was a surprise. But I thought I was still the same surgeon, right? Just doing a different
Mhm.
job. And then coming back, you have the whole different mindset of, instead of why did you leave and what's wrong with you, now it's what you could, why are you coming back? So
Mhm.
I get that mindset. And what I would tell people, having been through it on both sides, is you really need to spin it and figure out what the wins are for you, both in and out, so that you can speak to those wins and have them and have the people that you perceive to be judging you understand what the positives are.
Sure. Dr. Burlew, did you have a comment
Yep.
on that?
No, again, I completely echo what Dr. Nagel just spoke to. I think, again, each of us has a very different experience. My experience was a somewhat positive reason for leaving. It was I was standing up, right?
Mhm.
And doing something positive within my culture. And then coming back in was related, I was delayed due to medical reasons. Well, I think all of us can understand, if you're a patient, what that does to your life trajectory, and if there are bumps in the road. And so I completely agree with Dr. Nagel that you have to tell your story and why you are where you are, and why you are continuing. What is the purpose for you? Why is this a positive move for you? What was important about the step you took to exit and the step you took to come back in? So although to me, if there's negativity, it was really because people didn't understand why I had done what I did, or why I was coming back in, or what the delay was. Other than that, I felt general support for the reason that I was gone. I do think that maybe some of the different questions and the different comments that we're sort of skirting around the issue of what's too much time. At what point are we affected to the point that we are having problems or having complications, or need to be, proctored, more than just sort of a, hey, I'm going to go do this case I haven't done in 9 months, and it's a little bit more complex, and someone available. And I always hate asking questions I don't have an answer to. That's, I mean, surgeons hate not knowing the answer to stuff. But I think that is maybe a little bit of what we're hinting at, which is, and each institution probably has different ways. Some, it appears, have no quote unquote reentry pathway, or say if you're gone for a year, or again, I don't know if there are arbitrary numbers around that. So I'd be curious if others have more set numbers that they know are absolutes in different organizations or in different practices. But I think that's, to me, there wasn't a set, if I wasn't back by a certain time frame, then I could no longer do this.
But also, do you feel that for each specialty, that time off might be looked at in a different way? I mean, because of the complexity of the procedures that they might be doing or might not be doing. For example, if someone who was only doing breast and they took 6 months off versus, I don't know, someone who's attending to trauma, like a level 1 trauma center, and they're a trauma surgeon and they're gone for 6 months. Is it looked at in a different light?
Well, speaking as a trauma surgeon that took 9 months off, I hope not.
Okay.
You know, I don't know if there are, I mean, each of us has a different practice, but I think I'm back to echoing has anyone really looked at what the critical time point is?
I don't think we have that data, do we?
I don't know that, but I would actually echo that thought in that, yes, I was out for 3 years, but I was working in medical device. I was actually operating, not on living humans, but did operate, was still was engaged with the surgical world continuously. And so when people disengage, what is that time frame that says, I've been out for a year and so much has changed, and so much, not even changed, but I just don't even remember the day-to-day nuts and bolts like that. I think that's a really good question, Dr. Burlew.
Yeah.
You were operating in a lab environment, so you still kept the skills up because you were doing things right? When you were away.
So that's why I felt comfortable, but I also did have, I can tell you my cortisol level was through the roof doing cases on human beings again, because it's just a whole different ballgame, right? And if you're, and if you step away entirely for a long period of time, I can imagine it would be hard to get some level of confidence and comfort back to engage on the level that we do as surgeons.
Dr. Lal, you had a comment.
No, I was just thinking, I was just nodding to Dr. Nagle's comment because that's kind of exactly it, that I don't think there's any data. I think I agree with both of you. But what I have seen floated, because I explored this issue because Dr. Nagle, I've been looking at kind of stepping out. I have this sort of side gig and I'm consulting business, and I'm like, well, I'm doing both right now because maybe at some point I just want to do one. And like you, I'm thinking, well, what if I don't want to do just one and I feel like I want to come back? And what I see being put forth, but I don't know what the source data is this arbitrary thing I hear is about 2 years. And I think it's because of malpractice, because of
Credentialing.
concerns, credentialing concerns, because I think most hospitals are on 2-year credentialing term, things that I think that's the reason, people, I was counseled, like you said, don't, even if you have to do locums on the weekends, keep your hands in if you think you are ever going to come back. Now, I realize all the leave circumstances that we've talked about, we could not do that, right? So there are going to be circumstances where you can't keep up your clinical skills, and no one knows what, no one knows what that time period is. But I'm seeing anywhere from 1 year to 2 year being thrown about, but I don't know what the data is,
Sure. So, if any of you had any closing statements, I would welcome them now. Otherwise, I think we're coming to an end of our webinar. Is there anything you wanted to share, Dr. Burlew or Dr. Lal? Dr. Nagle? Okay. All right. So go ahead.
Sorry, I will just say, I think to re-echo what we've said before is that you need to do what you need to do, right? The negativity will be there, in the words of Taylor Swift, haters gonna hate, right? So it will, so it's when you're leaving, there will be criticism. When you come back, there will be criticism, jealousy, questions. you have to stay true to yourself. So do what you need to do so that you can be the best surgeon, provider, father, mother, daughter, caregiver, whatever, that's the driving factor. The
Mhm.
other things can be worked out. You can't stop people's thoughts. You can't, change people's thinking. You can,
Life happens.
right,
Yeah.
life happens. We are human just like our patients. We need time off for surgeries. We need time off for caregiving, etc. And you do what, works best for you. I'm hoping that our organizations like ACS, etc., will start to look at these arbitrary things that we've seen in the comments, like I can't even be a surgical assist because I don't have a case log for a year, things like that.
Mhm.
And have kind of formal guidelines on how this can be done. I agree that not enough is being done, probably because before people didn't take these timeouts, but as the culture has changed and as people are looking at alternative pathways, side gigs, re-entering, etc., I think that conversation needs to be had.
I'd like to thank everyone for joining us today. Thank you to the audience, and thank you to Doctors Burlew, Lal, and Nagle for giving their time and sharing their experiences. On the screen, there's more information about connecting with Women in Surgery Committee and upcoming webinars. I do thank all of you, and we hope you will join us again soon. Thank you all. Have a good night.